Yes. Good evening, everyone. This is Amy Morton, and I'm welcoming you to this call this evening, and that's being hosted by Chuck Shaheen and International City Medical Consultants. And we are happy to have you with us. And during the call tonight, you're going to have an opportunity to ask questions. And you do that by just pressing 7 on your phone. And when you do, you'll be put in the queue to have your question answered. So please remember to press 7 if you'd like to ask a question after you hear from our panelists. Thank you.
This is Chuck Shaheen, and I would like to welcome everybody to the call tonight. I'd like to ask for a special blessing on our first responders, our EMT, our firemen and policemen, and especially all those at Houston Healthcare, including all the physicians and the staff. They are truly on the front line. I would like to take this time to welcome Dr. Maher Abdulla and Dr. Scott Edenfield, two of our leading physicians that are always providing good health care throughout our community, and even more so during this difficult time to fight this coronavirus. Dr. Edenfield, if you would like to say a few words of what's happening at the Houston Healthcare Hospital, and then I'd like to turn the program over to Dr. Abdulla. Thank you.
People will say, oh, it's not as bad as they say, blah, blah, blah. You know, the media is playing it up, but that's not the case. This is a bad, bad situation. It's hit certain areas certainly worse than we've experienced here in Providence, but I tell you what, we have gotten plenty of illness here in Warner Robins. People are downplaying the social isolation, the social distancing. That's exactly the way this is going to be dealt with, at least initially. You keep away from people. You minimize the asymptomatic transmission of the virus from person to person. 25% of infected patients are totally asymptomatic. They can be walking around spreading COVID-19 to others around them. Younger people seem to be more cavalier. They want to go out and have a good time, and they just can't believe this is as bad as it is, but it really is bad. Of all the illness, luckily about 80% of people will have a mild to moderate symptomatology. Most of them will not require hospitalization. About 20% will be sicker, worsening symptoms, shortness of breath, severe cough. A number of those will definitely require hospitalization. About 5% of people get extremely ill. And of that 5%, I think the latest number is about 1.4% of them will die. And this can be a fatal disease. Why it hits some people harder than others, we don't really know. We know that people with comorbid conditions such as diabetes, high blood pressure, heart disease, autoimmune disease, they seem to be a bit more susceptible, or they seem to be less able to combat the virus. Hopefully in the future, well, the social isolation, that's, people are still going to get the disease, but hope that you've heard them say flatten the curve, flatten the curve. What they're trying to do is as this virus makes its way through our population, they're trying to slow down the transmission in the person. And in doing so, when they say flatten the curve, what they mean is we're going to get a spike, but let's lower that spike, because if we don't lower that spike, this illness, if it hits us all at one time, is going to overwhelm our ability to take care of sick people. It's going to overwhelm the hospitals. It's going to overwhelm the ICUs. It's going to overwhelm our ability to ventilate people with ventilators. If we can spread that out, we'll be able to take care of people better. And hopefully in the future, we will have other things to fight this. Maybe they will come up with a dependable regimen of medications. They're working on a vaccine that's probably a year away, and we'll eventually overcome this, but this is not going away immediately. It's going to die down during the summer. It's going to flare back up in the fall, and I don't know how many times that cycle is going to be repeated, but it's here to stay, and we just have to learn to live with it and cope with it. And I'll just
Thank you, Dr.
let someone else.
Thank you, Dr. Edenfield. I know you have more to say. I just want to quickly remind people that as they listen, if they have questions, please press 7 on your phone to let us know, and we will put you in line to ask questions. We literally have hundreds of people on the call this evening, and so we are very grateful for the time of these two physicians. So go ahead, Dr. Edenfield. I didn't mean to interrupt you.
No. I guess that was my opening statement, but I'll be glad to chime in anytime you need me to.
Dr. Abdulla, would you like to share some information with us initially, and before we move to some of the questions that are pending? Could you do that, please?
Yes, I could. Thank you very much for this opportunity. It's good to hear a voice of my friend, Dr. Edenfield. I have not seen him in a while. I think he is trapped in the ICU, seeing all these sick patients on ventilators. I'm sure he's saving lives as well. Well, this SARS is not new. Actually, this is version 2, I would call it, because it started to get known in 2003 with SARS-CoV-1, and without a doubt, SARS-CoV-2, the one we have right now, which is COVID-19, which is coronavirus 2019, that was first discovered in Wuhan, China, is probably a mutated version or a virus which is the descendant of its ancestor SARS-CoV-1 or SARS-CoV that has been described in 2003. The difference is that this version spreads very easily from human to human, and it became a real pandemic once it departed from China with carriers who were symptomatic or asymptomatic. And we know now that 4 out of 5 patients with COVID-19 have gotten the disease from somebody or someone who did not know he was sick. And this is where the danger resides. We do not have mass testing for this virus in the United States, though effort is being put out to get everybody tested if possible, but it is impossible to do it at this stage because of the speed the infection is spreading. So once we know the denominator, which is how many people carry this virus, we will get to realize the extent of the disease. But I know that the ICUs, the emergency room, the med staffs, even doctors' offices are being overwhelmed by people who complain of symptoms or signs or both of this infection. A lot of them actually probably don't have it. Either they're panicking or they are having other upper respiratory tract infections, which definitely coincide with COVID-19. Every day we discover that we did not know anything about this infection. And unfortunately, there's a lot to be known. There's a lot to be studied. There's a lot of things that will change in terms of our knowledge of this virus. It is very sickening. It does kill, without a doubt. It is much more serious than influenza. And it could kill somebody with no pre-existing or comorbid condition. But definitely those with pre-existing conditions, whether lung or heart or immunosuppression type problems, are going to be more likely victims to suffer long-term complications. And a vaccine is needed to stop this virus from killing more people. And more than that is we need time. We need time to survive in it so that we develop the so-called herd immunity, which is the immunity that humans develop when a lot of them get this infection. And this way, when another turn or another cycle or another storm of COVID-19 hits, the impact on the population will be a lot less intense and a lot less morbid or fatal. So hopefully eventually we will do well. Hopefully eventually this infection will subside and get under control with the development of the vaccine and development of the herd immunity, and definitely developmental medications that could help us treat it when it happens in a timely fashion.
Thank you, Dr. Abdulla. Again, if you would like to ask a question, please press 7 on your phone and you'll be placed in line. We do have a lot of questions, and as I said, there are hundreds of people listening to this call because this is obviously an issue that impacts us all. So I'm going to move to the first question now, and both doctors may want to respond to this. The question is, how does anyone know, or does anyone know for sure, how COVID-19 was caused or got started?
I guess I'll take that one. I don't know that anyone does know. There have been all sorts of theories. You know, supposedly it originated in bats and it came out of the wet markets in Wuhan, China. I don't know that anybody truly knows the answer to that. I've heard several theories. That seems to be the most popular theory. But in point of truth, I'm not sure that people really know how this came about.
Okay. Any other comment on that question, Dr. Abdulla?
Yes, I will add that the genetic diversity of COVID-19 virus is very limited and very small. And the genetic diversity refers to the total number of genetic characteristics in the genetic makeup of the species, which is this positive sense RNA virus, which tells us that the spillover event that caused the development of this virus has happened sometimes in the late 2019. So definitely this is a new virus. We do not know the host or the intermediate host of this virus at all. We know the host for the first SARS virus, which is raccoons, dogs, and civets, but we're not sure where did this virus come from, which adds to the ambiguity and actually the danger of this virus. But this is a new virus to humans at least. Whether it has existed in the wild, possible, because, you know, the Chinese culture is a little bit different. They eat wild animals and they have wild animal markets. And the contact between these wild animals and humans is not known except in few areas of the world, including that market in which the outbreak started. And unfortunately, now we have to deal with COVID-19 as an infection in which the host is mankind, unfortunately.
Thank you, Dr. Abdulla. If you're with us, and we still have many people who are on this call, and you'll want to stay because we have a lot of good questions that are in the lineup here. And I want to remind you, if you want to ask a question, please just press 7 on your phone. The next question is from a retired nurse, and she would like to know whether the answer to this question. Recently, the president voiced support for the use of two drugs, hydroxychloroquine and zithromycin, as treatment for COVID-19. Are these drugs proven to be effective treatments? I think we'll go. Who would like to take that?
I think Dr. Edenfield has been treating patients with these drugs. I think he will have the better experience with them.
Well, I don't know. There are no like long-term, double-blinded studies to prove the efficiency of these medications. You know, this is kind of an emergency situation. When that happens, some of the things we normally do, we push to the side. A lot of these are just almost like case reports. You know, we treated 18 people in Wuhan, China, with this combination, and it seemed to work. They're currently doing more specific trials for the drugs, but the initial data from limited trials that might not necessarily be double-blinded seems to show that there is a positive effect by sometimes some of the studies are with hydroxychloroquine alone, some of them are with hydroxychloroquine and azithromycin together, and in fact the data is strong enough to where it is standard procedure that if we admit somebody to our hospital who's highly suspected of being COVID positive, even though they may not have a positive test yet, they are automatically started on hydroxychloroquine and azithromycin.
Thank you. Next, we have a question from a woman in Warner Robins who's 88 years old. She says that she's been scheduled for had been scheduled for a cataract operation in April, but that's not going to be possible now, and that's now been rescheduled for May. She wonders if you believe that we will still be in the same position in May, and I can start with Dr. Abdulla this time.
Yeah, I think we are going to have a problem, in my opinion, until the hot weather really settles in very well. We are sure that coronavirus in general is heat sensitive, but we are not really sure if this COVID-19 will subside in the summer itself. But we hope by that time we should have been past the peak, and a lot less cases are being reported, with a lot less morbidities and mortalities as well. And then maybe in August and September we will get a good break. We hope so. But I believe come fall we will have the storm or the spike or the increase in number of infections all over again. And now it's going to be, we don't have to wait for somebody to come from China with the infection, because we already have it in the United States. So at one stage, we will always have somebody who carries that virus who will pass it along, and another cycle of infection will start. But we hope as time passes by that we will have less incidence and prevalence of that infection. And we hope before it's too long we will have a vaccine, though I don't think we will have a vaccine anytime this year. That's what I guess, but it could be, I mean, miracles can happen, but it takes almost 18 months to produce a successful vaccine that can be given to the population. And I don't know if Dr. Edenfield agrees with that, and he could add to it if he thinks he has something.
Yeah. Dr. Abdulla, everything you said is absolutely correct. The peak in Georgia is estimated to be around the 21st to 22nd of April. They think that's when we're going to see the apex of the number of cases that we're going to experience, and after that it will drop off. Now, drop off is good, but drop off doesn't mean it's going to go away. Drop off means we're going to have lesser and lesser and lesser cases, I would imagine that we'll still need to some degree, to socially isolate, socially distance ourselves. Hopefully people will be more attuned to washing their hands, using alcohol, disinfectants, not manipulating their face, and introducing a potential virus to their, ears, eyes, nose, mouth. And he's exactly right. It'll be at least a year before we get a vaccine. If you'll notice, when they talk about this virus, they call it the novel COVID-19. And what they're saying is, by using the word novel, they're saying we have never seen this virus before. This is a new virus. Our population, the world population, has never been exposed to it before. There is absolutely no herd immunity. Back when we study your history books, when Columbus came over to the Americas, apparently they brought smallpox with them, and apparently it decimated the native populations because they had absolutely no exposure to smallpox. And that's kind of what we're experiencing worldwide here. No one has been exposed to this virus, so everybody is fair game for this virus. Everybody can get infected. Luckily, it damages some people much less than it does others, and we don't really know why the difference is. But this is going to eventually work its way through the entire population, or at some point we're going to get a vaccine, and those that have not been exposed to it will get their immunity through the vaccination. But that's, like Dr. Abdulla says, that's going to be probably a year away.
And Dr. Edenfield, I'm going to stay with you to ask the next question, because I think that this may be something that you are directly familiar with because of your work in the ICU. The question is, what therapies are they using in Houston County, and how effective has treatment been?
Well, that's kind of a broad question. Are you talking about antibiotics? Are you talking about just general therapies, or what?
Well, I think that they're just talking about general therapies, so I will allow you to answer that any way that, in any context that you're comfortable. From your experience.
First of all, if you get admitted to Houston Medical Center and you're suspected, you're going to, unless there's a contraindication, you're going to be placed on Plaquenil, hydroxychloroquine, and azithromycin. If you're really sick, there's another antiviral called remdesivir that may be administered. There is another AIDS drug combination that is sometimes used. I don't think we're using it here yet, and hopefully we won't have to. Of course, after that, the treatment is symptomatic. There's a lot of ambiguity in the treatment of sick COVID patients. The one thing we're looking for is their ability to breathe. That seems to be the Achilles heel, if you will. Almost everybody will get some pulmonary involvement, but some will be much worse than others. You try not to intubate somebody, put a tube in their airway, and put them on a breathing machine if you can help it. However, if somebody is obviously taking a fairly steep downturn secondary to COVID-19, we generally try to intubate them earlier rather than later. Of course, that taxes our ability to, we only have a finite number of ventilators, and we're always trying to keep some in reserve, because you never know, who else is coming through the door. But many hospitals are finding themselves running short of ventilators. Hopefully we'll never get to a point where we have to make a decision whether somebody gets a ventilator or not. If they seem to have a secondary pneumonia. Oftentimes when you get a viral pneumonia, you will sometimes get a secondary bacterial pneumonia because of the damage done to your lungs, your airways. We'll oftentimes start them on other antibiotics if it's deemed necessary. Oftentimes when we take care of really sick people in the ICU, we give them lots of IV fluids, keep their blood pressure up, keep their kidneys working. That's actually counterproductive in a COVID patient, and that leads to problems. You actually want to have a COVID patient run a little bit on the, quote, dry, close quote, side or dehydrated state. You want them to be a little bit dehydrated. They seem to do better with that. Of course, if somebody is septic, you're going to have to give them some fluid. It's recommended that maybe you even start giving them a vasopressor, a drug to keep their blood pressure up before you start giving them lots of fluids. Of course, keeping their oxygenation at an adequate level. A lot of these people get severe lung disease. We call it ARDS, Adult Respiratory Distress Syndrome, and they are they can't breathe on their own. They have to be on a ventilator. They are very difficult to ventilate. You kind of have to work your magic on the ventilator and try to keep their oxygen level up as best you can. We're actually doing something called proning, P-R-O-N-I-N-G, and that's something that we did years ago when I was in training, but it kind of fell out of favor, but it's coming back into favor. A lot of times when somebody's on a ventilator lying on their back, they get a lot of fluid accumulation and they get what we call atelectasis, or collapsing of their lung on the dependent side, the back side, the side that's down to the bed. What you do is you simply flip them over. You lay them almost totally on their abdomen. You don't put them exactly on their abdomen, but you turn them like, maybe 120 degrees, and you leave them there the better part of the day, and of course you've got to move them around a little bit so they get pressure sores, but then later in the day you'll put them back on their back to give them a break. But there are all sorts of novel approaches to supporting people in the ICU. There's all sorts of things that are being discussed but haven't been proven, like high doses of vitamin C, the use of thiamine. It's very controversial whether or not they need steroids. We frequently use steroids a lot. Well, the common thought right now is maybe you should avoid steroids. So, you're trying to do your best to keep the patient alive. Hopefully they will recover. Unfortunately, I'm a pulmonologist, a lung doctor, and most of the people we put on ventilators will eventually get off the ventilator. Some don't, but most do. Unfortunately, with COVID, the survival once somebody has gone onto a ventilator is pretty dismal. If they get sick enough, they have to have a ventilator. There's about an 80% mortality rate. If you go on the ventilator, there's about a 20% rate that you will come off of the ventilator. So,
Dr. Edenfield,
ma'am,
can I ask a question? I'm going to try. We have about a dozen questions pending, but I'm going to group. There's several around prevention, since we're talking about the really serious impact of this disease. And several of those questions involve two things. One, is it important? Does it matter? Is it important to get a flu shot? And the other question is whether or not the CDC's guidance about wearing cloth masks is good guidance. Is that guidance we should follow? And if so, do the masks really help to stop the contraction of the virus?
Well, getting the flu shot is never a bad idea. It really has nothing to do with what's going on now with COVID. But as you probably know, a lot of people who come in thinking they've got COVID will actually have influenza. And so a lot of the symptoms are very similar. So if you've gotten the flu shot, you have a better chance of not developing the flu. So that's one less problem you've got to deal with in diagnosing a COVID patient. As far as the masks, the N95 mask is actually the gold standard. That works better than anything else we have, and of course, unfortunately, they're in short supply. They're supposedly ramping up production. At first, the government recommended that you not wear a cloth mask because these particles are very small and they're really not, you can't depend on these cloth masks to block out these small viral particles, and they actually may give you a false sense of security. You're wearing this mask, you might let your guard down, you might get in some type of situation where your exposure risk is much higher and you think, well, I got a mask on, I'm okay. I would only feel that way with an N95 mask. But the government has, in the last week or so, they have started to recommend that you do wear a mask, even if it's a cloth mask. And I think their rationale is that if somebody's coughing, the particles that they aerosolize are kind of large, and a cloth mask may block out some of these particles that might otherwise have been, coughed into the environment. So the government has kind of changed its tune on that a little bit, although it's not a perfect solution. It is, something you can do, but you should never forget that that might give you a false sense of security because that's not really the proper mask to use in this environment.
So you would say still practice social distancing, it sounds like, and that as part of prevention, even if you were wearing a cloth mask. And Dr. Abdulla, I'd love to get your thoughts about that. And also another question that is related to that is whether or not someone can contract the virus from handling food touched by others at the grocery store who may be carrying the virus.
Yes, and this is all related to your social habits and how clean you try to be and how much hand washing you do. It really boils down to these things. We know for sure right now that the virus does survive in droplets that do settle on surfaces, particularly steel surfaces and plastic surfaces. They have shorter half-life if they settle on cardboards or on copper surfaces. And definitely if you happen to touch a steel surface that has droplets from somebody who sneezed in an unhealthy way, and then you rub your face or rub your eye or touch your nose, you could definitely get that infection according to the epidemiologists. So we now learn that we have to do frequent hand washing. Whenever you remember, you just have to wash your hands as frequent as you could. And if even washing the hands became an etiquette, it became a style. So you should learn how to wash your hands, and don't forget to use the soap. Don't forget to do it for 20 seconds at least so that you get the best out of it. And like Dr. Edenfield elaborated earlier, that yes, I mean, you put something in your face, whether it's a surgical mask or a cloth mask, it's okay, knowingly that you still could get the virus if you feel lax and you are closer to somebody who might harbor or carry the virus and he's asymptomatic. So you have to be really careful. And even if you have a mask, you have to keep the distance of 3 to 6 feet, ideally 6 feet. And we have to know also that circumstances could change if you are in a wind current type place. you don't have to wait for a droplet to touch you so that you could sick. You could have the infection from a way where it's called airborne, where the droplet nuclei, which are smaller than the droplets, are still hanging and floating in the air, and you could just inhale them. So if you have no business being outside, stay home. You don't have to go shopping because you are bored. It's a gloomy situation. Try to restrict yourself by keeping activities indoor as much as possible until the clouds are cleared from the skies, and then you could do whatever you want, hopefully. But definitely prevention is the way to go here, because we have neither a definitive treatment and we don't have a vaccine. And prevention, and 1 pound of prevention is better than a ton of treatment, of course, like they always say.
Well, and I have several questions, and I'm going to try to combine them, from people who are concerned about individuals who have had the virus in the community who are returning to work. And they're wondering if that's truly safe. If there are individuals who have had the virus and they've now returned to work, does that pose any special risk in the workplace?
Well, they're always going to pose risk. To tell you the truth, you, in the most ideal situation, you cannot release those sickly individuals who were once known to have COVID-19 back to work unless you test them twice, 48 hours apart, and they are PCR negative through a nasopharyngeal swab. So it's not enough to check their blood for the antibody, which is the rapid kit test. It's not enough. You have to really make sure that they are PCR negative through a nasopharyngeal swab, which is a very unavailable test. It takes so far 48 hours. I don't think we have the 15-minute kit or the 2-hour kit that can come back in no time. So yes, it is very risky, and they could still carry the virus, though they have shown that they are in remission, or they have no more symptoms, they have no fever, no cough, and no shortness of breath. Yes, without the second confirmatory test where there is a PCR negative swab, you cannot be sure that this patient is safe at all.
The question came back up, and either of you can answer it too. Sort of tagging on to that is whether or not anyone knows whether these protocols that are in place in Houston County, and whether what you're saying is the virus can basically be asymptomatic. The person who's had it can be asymptomatic but still carry enough virus to be a risk to those around them. And are the protocols in place that you just described before people return to work in Houston County?
Well, I think there are two things to remember. Up to 25% of people who are COVID-19 positive, and may not know it, are totally asymptomatic. I mean, it could be your next-door neighbor. You walk over and say hello to them. They may be COVID positive from some prior exposure. They feel great. There's nothing they feel wrong with them, but they are infected. They are spreading the virus. They can transmit it to you, even though they have nothing to warn them that, hey, I better stay away from other people. The second point is, I think I read where maybe upwards of a quarter to a third of the COVID tests are false negatives. In other words, they're read out as negative, but in point of fact, the patient is infected and is positive, but the test is incorrect.
Well, that's thank you. And I have one more question, and I'm going to try to pronounce this correctly, and I hope that one of you will correct me. What about the use of Acmera for treating COVID-19? The drug is an IL-6 inhibitor. It's
chloroquine. I believe you're talking about chloroquine. Okay. There's hydroxychloroquine, and there's plain chloroquine. hydroxychloroquine, which is Plaquenil, we use for autoimmune diseases and such. Plain chloroquine, if I'm not mistaken, I'd have to verify that, but is an anti-malarial drug.
Correct.
You know, the servicemen have to take it if they go into endemic parts of the world where malaria is, you know, very common. They take it prophylactically, and of course, if they get infected, they take it therapeutically. But I believe that is the brand name for chloroquine. And most of the studies seem to be focused on hydroxychloroquine or Plaquenil.
Okay, great. I have a follow-up question about that from someone who says that they are previously they were a Plaquenil lupus patient and were told that it took up to 90 days for the drugs to take full effect. Is that correct or not? And we're
talking about two different they're probably referring to their treatment as far as the autoimmune disease. Now you're using it as an anti-infective agent, an antimicrobial, if you will. And that's two different. I don't know the data on that, but I mean, my gut feeling is hydroxychloroquine or Plaquenil is effective much sooner in this particular situation than in an autoimmune disease such as systemic lupus erythematosus.
And one last question, and either of you can answer this. Dr. Abdulla, you've been quiet for a moment, and this will be our last question this evening. About after this is answered, just say to the people who are continuing to hold, we're going to have one final comment, and then if you've not gotten your question answered, if you will stay on the line after the call is over, you'll have an opportunity to leave your question on voicemail, and we'll do our best to get you an answer. The last question is, and I don't know if anyone on the call knows this, is when are people going back to school and work considering this disease, especially with the consideration that there may be an increase in the fall? And does anyone know, this is not a medicine question, it's a community question, what are we doing as a community for people in economic distress? Anybody have any idea about either of those things?
The way I look at this, and I don't mean to be flippant about it, but we're kind of making this up as we go along with some scientific input, you know, and this is not totally pulling it out of your hat. It's done with some knowledge, but I think they're making recommendations that they, you know, it's not like somebody did a study and said, well, you know, if you socially isolate for 2.5 months, then everything should be back to normal. As Dr. Abdulla would tell you, I don't think we know when things will be back to normal. You know, but like everybody's talking about, you know, how long do you keep the economy shut down? I mean, nobody is doing anything, you know. I mean, restaurants are closed unless they have curbside delivery or pickup. Many businesses like movie theaters and roller skate rinks and all that stuff, they're all closed. And you know, the whole economy has been shut down, and I think they're looking for the sweet spot where we can open things back up and not expect a huge spike in cases. And to be honest with you, I have no idea when that is. I don't think anybody does. And to be honest with you, I really would have to criticize our governor. I don't know what he was thinking. He probably had some information that Dr. Abdulla and I don't have access to, but I think our governor kind of missed it, at least from a medical point of view. I mean, he should have put down shelter-in-place orders a long time before he did, and I think that his inaction probably will lengthen you know, our pain. I just don't agree. He should have done something quicker than he did. I mean, I think Mr. DeWine, Mike DeWine in Ohio, is probably the gold standard for all governors. He jumped right on it, and he got to it, and they've had some disease, but I think it was limited because of his action, and I think our governor was a little bit slow on the uptake there.
Thank you. We have had you both have been wonderful. I'm going to turn this back over to Chuck Shaheen for a moment. And I know I did want to ask one follow-up as I do that. And Dr. Abdulla, I didn't hear you comment on the flu shot. Just briefly, do you, yes or no, think that flu shot is a good idea for folks?
Yes, I absolutely say that all patients should have flu shots, and those who are qualified or recommended to have the pneumonia shots definitely should get them, because you have to remember, influenza can still happen in a patient who has COVID-19. Pneumonia can still happen to a patient who has COVID-19. And this is another reason for him to have a more riskier course, sicker in-hospital lengthy stay, and definitely that patient who developed influenza on top of COVID-19, or he had influenza, then he had COVID-19, will have a higher chance of mortality and morbidity and loss of function and being sicker for a long period of time. So without a doubt, it does help, and we don't know how much influenza vaccine helps, because now we realize from anecdotal data that people who got vaccinated with BCG vaccine, which is a tuberculosis vaccine that is given elsewhere in the world, have fared better in terms of COVID-19 infection, because as an immunomodulator, it does help your immune system fight other infections, including COVID-19. So people who got that BCG vaccine at one time as a child for TB and came to the United States, or had the COVID-19 somewhere else, we know that those people could definitely do better in terms of infection. So yes, vaccination for flu, vaccination for the pneumonia, absolutely are recommended, because they help you fight other infections and may help you modulate or mount a good immune reaction if you happen to be unlucky to get COVID-19 infection.
Thank you. Dr. Edenfield and Dr. Abdulla, do you have any closing comments before I turn this back over to Chuck Shaheen?
I'd like to applaud Dr. Abdulla. That was a very good point that I had not made. The pneumococcal vaccines. Of course, right now they're limited to people over 65. There are some exceptions to that, but that is very important that anybody who is capable of taking the pneumococcal vaccines should take them. Although your insurance company may limit it to being over the age of 65.
Dr. Abdulla, any closing remarks?
Well, I will tell you honestly, life will go on. We may be in this for 10 to 20 months. I honestly don't have definitely a bright view of the near future, but the long-term future, or the future in 2 years, will be much brighter. We need the vaccine very bad. This is the only way that we could get our life back together. We could get our business and economy going. As long as the circumstances are status quo, we will be scared. Economy in this country and in most westernized countries is consumer-driven, 70 to 80% consumer-driven. And if the consumer does not go out and spend, is not going to move. But at this time, you have to know that your life is at stake. So take it easy. A few more months won't hurt you, as long as you stay alive and don't get sick. Social distancing is important. Sticking to healthy hygienic practices are essential or is essential. And we just hope that better things and better times are ahead of us.
Very good point.
Thank you. And I'll turn it back over to Mr. Shaheen.
Thank you so much, Dr. Edenfield and Dr. Abdulla, for this pertinent information that you provided tonight. Your information could save and prevent this disease from spreading. I want to thank our listeners tonight. If you didn't get your question answered, please leave me a private message on Facebook. In closing, as always, Robins Air Force Base is the heartbeat of our community, and the small business owners are the backbone of our community. Please keep our educators, our kids, and our elderly family members in your prayers. We have a great city. Our citizens are always come together to build a better place to live, work, and play, and retire. We want to thank you again for fighting the disease, Dr. Abdulla, Dr. Edenfield, for what you do for our community. This concludes our telemedicine call for this evening, and I want to thank you very much.
Thank you, Chuck.
Thank you, Chuck. Thank you, Chuck. Thank you, Scott. Thank you, Amy.
Thank you, Maher.
Thank you.
Good to talk to you.
Same here.